I'm going to present a case on premenopausal and postmenopausal AUB, describe its physiology, and explain the diagnosis and differential diagnosis, and review the recommendations in the management of AUB and during the pandemic. Okay, so first, I'll just have a poll from the audience. I just want to know do you know what is the top most common gynecologic complaint? So ano na lang sa poll. Is it A, pain in the lower abdomen, vaginal discharges, irregular bleeding, dyspareunia? Okay, I'm going to set it at 30 seconds. Hindi naman yata mahirap ang question. Okay, we'll end the poll. Okay. So it's 78%. You're right. But actually, the close to the irregular bleeding is vaginal discharges. So ito yung top 2 earner ng isang gynecologist sa ating outpatient. Okay. So just a quick so we have to level off on some definition. When we say there is an heavy menstrual bleeding, it is an excessive menstrual blood loss which interferes with a woman's physical, social, emotional, and or material quality of life. So it is a symptom of excessive menstrual loss as perceived by the woman rather than meeting an objective diagnostic criterion. So it is not quantifiable, itong excessive menstrual blood loss. Sometimes we presume that our patients are medyo overacting when it comes to vaginal bleeding. Ay, konti lang naman yan, ganon. But if it is affecting her emotional, maternal quality of life, then that is a heavy menstrual blood loss. Okay, so Professor Monroe, who is the chair of the Committee on Menstrual Disorders, mentioned that it affects around 3 to 30% among reproductive age women. And the reason of which is it's wide in spectrum, no? In terms of estimates, and it varies by age. And if you notice, it is higher in the during adolescence, and it is also higher at the extreme age of reproductive age group, so in the 5th decade of life. So around 35%, it increases by 35% if there is intermenstrual or irregular bleeding. And it accounts to a third of OPD consultations. So I got the raw data from my hospital, SPMC, the census for 2020. We had 897 total gynae admissions, and 162 of them, 2 of those cases are due to AUB. And that totals to 18% of the total gynae admission. And that is, majority of them is for correction of severe anemia or for a definite intervention like a hysterectomy. So some fact check. One, we have to know that HMB or AUB is not a symptom, but and not a disorder. So hindi ito yung myth na pag dinudugo, ano daw to, meron ka ng sakit, no? So it's just a symptom. And it is not life-threatening. Instead, it is life-altering. And 30%, there's a high prevalence of iron deficiency because of the effect of the prolonged AUB. And of course, it affects cognition, work productivity, family, and social life. And the most important thing is it is an unappreciated and overlooked health issue. So we are being taught, women, that that is part of our being a woman, that we have to bleed every month, no? And it doesn't matter how many or how long your bleeding is, but that is part of being a woman. So I'm now going to present to you Miss Sarsi. So Miss Sarsi is a 33-year-old gravida 1, para 1, and she was complaining of heavy menstrual bleeding for 2 months until the present time. She's sexually active, BMI of 26. She consulted for a second opinion. Pelvic exams were negative, and there is a sign of active bleeding. So this is her menstrual. So this is her menstrual history. So in September, October, November, her menstruation were all normal. It said it is always on the 11th, 10th, or 9th day of the month, and 5 days in duration. That December, last year, December, she had no menses. And of course, because she's sexually active, she had a pregnancy test. It was negative. And then, expecting for her menstruation for January, she had this vaginal spotting for 2 weeks. Then after the 2 weeks, she had this heavy menstrual bleeding expected, as predicted, on the 12th day of the February. And she consulted by teleconsult to her first doctor. Her first doctor said, had performed a transvaginal ultrasound and it was thick. And immediately, she was told to undergo a diagnostic curettage. Of course, most of our patients are scared of of entering a hospital. Instead, she did not follow the advice of the doctor. Instead, when there's another episode of heavy bleeding on March, she's consulted the second doctor, and this second doctor gave her OCPs and tranexamic acid. So now, and this is the ultrasound that she got. No? And I'm not going to explain to you the ultrasound. I'm going to explain it to you later. Okay? So obviously, it is a thick endometrium. Okay? So now I'm going to ask for a poll again. So based on the clinical data and ultrasound report, what would be your first course of action for Miss Sarsi? Start hormonal treatment, perform CISH, refer to for hysteroscopy, or do the standard DNC under anesthesia. There is no right or wrong answer here because this is individualized and depends on the clinician, on how she looks at the case. So I'm going to it in for 40 seconds. So we're about to, and we're going to stop the poll. And Paul, okay. So can they see the results? So it's a toss. You don't know. It's even. So some would choose a hormonal treatment. Some, 23%, would choose to perform an imaging, no, enhanced imaging of the uterine cavity. While others would refer for hysteroscopy immediately, and some would 22% would perform a DNC. So this is not a right and wrong answer, but it just shows to you that in the approach with somebody with abnormal uterine bleeding, it is individualized and it depends on the experience and on how the clinician perceives as to the case, like what I proved now in the poll. So that is what I am going to try to reset. Now, I'm just going to say to reset on how we can approach AUB, especially among reproductive age group, like Miss Vida. Okay, so now we can proceed. Now I know how to approach it. So this is the interprofessional approach to evaluating and treating AUB. Why is it interprofessional? For one thing, it is like this. This is the realistic way of doing on how we are practicing AUB or gyne. So in this case, it's Miss Sarsi. Miss Sarsi consulted me, the OB sono, and also at the same time a gynecologist. I am going to perform an ultrasound on her. And from the data that I'm going to get from the ultrasound scan, I'm going to approach to her like a clinician and a gynecologist. Okay? On the other side, we have here her clinician who sent Miss Sarsi to an OB gynecologist, but I rather call them as ultrasound specialists. And this ultrasound specialist will perform the ultrasound scan only. And all the data, historical data and pelvic examination will be performed by the clinician. And what I want to happen is that the approach and the engagement will be the same as the engagement of the clinician who performed the ultrasound for her patients. Okay, so it means that it is trying to understand what the OB sonologist or ultrasound specialist is seeing, and what is her diagnosis clinically, and correlating it with the ultrasound. And so that it has to be communicated to the clinician. So this plus and the arrow should be between the clinician and the ultrasound specialist. So I hope this is the interpersonal relationship that we are going to have in the approach of the diagnosis and treatment of AUB. So we already know about pump coin. No, it was introduced to us as early as in 2009, and this is a standardized way of using the its very makuti, no? So detailed. Actually, it's not, I don't know if it is not as popular. We do not use it routinely. In my clinic, I don't use it. I just, if I do a different type of algorithm when I make a diagnosis, and it is more usually ultrasound based. But here, when I made this lecture, and I realized that this FIGO, standard nomenclature, should be practiced because it is actually based on the etiology. And we have to treat the etiology and not the bleeding disorder, because the bleeding is just a symptom. Okay? So there are two systems within that FIGO nomenclature. We have that system 1 and the system 2. Now the first system, or the system 1, it gives us the definition of menstruation based on the four parameters: the frequency, duration, the volume, and the other one. I will discuss it. So those are the parameters for a normal menstrual bleeding. And it will be a guide to us if indeed this patient is having just a hormonal problem, or a structural, no, a structural etiology for AUB. But in this system 1, they remove these confusing terms like menorrhagia, oligomenorrhea, metrorrhagia, and DUB. No? And I think we are already practicing it. No? It has been quite a while since I've read or heard of these terms, no, in our practice. And they are now using these terms. So a chronic AUB is abnormal uterine bleeding, a majority for the last 6 months. An acute AUB, take note, it is bleeding sufficient requiring immediate intervention to prevent further blood loss. Okay, it does not say that it has to be less than 6 months. There is no time, it is not time bound. It is, when if there is intervention, then that is an acute AUB. It replaces metrorrhagia because it states that it has to occur in a cyclic, and it is predictable, no? And either in random or in the same day in each cycle. So these are the women who knows that it is already their time to menstruate, and they will complain that how come when I am about to menstruate, I am bleeding, spotting before I menstruate, and after I menstruate, I am going to have also some postmenstrual spotting. And HMB, or heavy menstrual bleeding, which is the most common cause of AUB, has replaced menorrhagia, and it is defined as excessive menstrual blood loss interfering a woman's quality of life that may occur alone or with other symptoms. So it does not state here that the menorrhagia or the HMB should be using 5 diapers a day. No, it is stating here it's more of the quality of life of that woman. Abnormal uterine bleeding is the umbrella terminology for all abnormal menstrual signs and symptoms arising from the uterine corpus. So hindi po pwede siya sa ibang organ. So abnormal uterine bleeding, uterus lang po yan, obviously. Okay, so this is what I said. So frequency, regularity, duration, volume, and loss. So this is the system 1 of FIGO. And if you notice the frequency here, the normal is 24 to 38 days. Okay? And regularity, the variation is 2 to 20 days. Duration, the normal is as long as 8 days. So prolonged is more than 8 and shortened is less than 4.5. And here, in the first FIGO, they stated the blood loss should be 5 to 80 ml. So this volume has been a point of contention among experts because for one thing, it is difficult to quantify blood loss. Okay, so there are a lot of studies who would do some pictorial blood loss assessment charts, no, to assess blood loss. However, there is lack of validity in these charts. So it is not recommended that we use this one, especially in clinical practice. For one thing, that it does not validate the use of the modern sanitary materials, because in feminine hygiene technology nowadays, paiba-iba sila ng composition. May maiba, di ba, they have may scented pad, then depends on the absorption of the blood. They don't want the blood to spill out beyond the edges of the sanitary pads, and the same as the tampons, no? So there's a lack of validity. So if there's lack of validity, so the accuracy in the estimation of blood loss using this pictorial blood loss assessment charts is not recommended. However, it can be used for research, no? For research. So in the revised, so that is what they are saying. So the ARCOG and ACOG was saying, now, why are you going to quantify volume of monthly blood loss? It should be patient-centered, that definition, like excessive menstrual blood loss that will interfere a woman's physical, social, emotional, and or material quality of life. So that is an indication for investigation and treatment options. Okay, so it is more, there is no need for an objective measurement of volume, especially when you are dealing with patients experiencing HMB. Okay. So another system that they used in 2009, this system 2. That system 2 will categorize the causes of abnormal bleeding. So it depends on the structural and the non-structural. And the structural is based on imaging or histopathology. So that's the PAM, the PALM. And the coin is the non-structural, which is C, coagulation, ovulatory, endometrial, iatrogenic, and not otherwise classified. So this is 2009. Now, I'm going to present to you the 2018. So that is around, uh, 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 that is 2009, 2020. So that's around, tama ba yung aking 11 years, 11 years gap, no? And as far as 2009, they also had this sub-classification. They were already using this sub-classification for myomas. And if you notice here, they use it as primary, secondary, or tertiary. So first, pag nakita dun sa ultrasound, is it present or absent? So that's primary. And if it is present, what is it? Submucous or not? No, submucous or not? So or other. So and if it is submucous, then you go to the tertiary. So tertiary, you have to identify what type of submucous myoma is present. Is it 0, 1, 2, or 3, 1 or 2? And the other, you're going to look at the other, to the topography of this other myoma. Does it contact the endometrium, intramural, subserous ba, more, 50%, subserous, less than 50%, pedunculated, and others. So they did this subclassification because they found out that it is really needed, especially for those women who are experiencing infertility and recurrent pregnancy loss. Okay, so but what is what is interesting here is we often see women with fibroids but are not complaining of AUB. And reverse naman, we have also lots of women having AUB but without presence of fibroids. Okay, and if there are fibroids, it's so small that for you to deduce that it might be the one that is causing the AUB. Okay, so that's why they made this subclassification of leiomyoma. So 11 and another is in the system 2, in the non-structural, I would like to point out AUB-C. So that is the coagulation. Coagulation abnormality, and it affects 13% of women and majority to von Willebrand's disease. Now, 90% diagnosed were using structured history for coagulopathy screen. So this is the screening criteria. Okay, so this is the screening criteria. So the first criteria is there should be heavy bleeding since the menarche, since the start of menstruation of this patient. Or the second screening criteria is one of the following. Is the bleeding, did she had an experience? Did this patient an experience of postpartum hemorrhage or a surgically related bleeding or bleeding associated with dental work? Okay, so that's the second screening. And the third screening is two or more of the following. Is she bruising 1 or 2 times a month? Epistaxis 1 or 2 times a month? Frequent gum bleeding or family history of bleeding problems? So any presence of the three criteria is a positive screening test. So I don't know if we are doing this regularly uh, with our adolescent patients, because this is what we have to do in screening our adolescents, especially our adolescent patients, because the heavy bleeding started since menarche. So most of the time, these women will really complain very early. Okay. So always remember in AUB in adolescents, there are only two causes, no, etiology. It's either ovulation or coagulopathy. So 20% of adolescent girls will experience a HMB, and 30% of them will be hospitalized for HMB and were found out to have underlying bleeding disorder. Okay, so we have to take note of this. So it is included in the protocol, especially among adolescents less than 18 years old, that AUB-C should be a differential diagnosis. Okay, so now we go to the revisions in 2018. So what changes did they do? First, amenorrhea was already included in the frequency of menses. Take note, meron na siyang absent. So you have frequent, normal, infrequent, meron ng absent. So amenorrhea is now part of the frequency category. Now, in terms of regularity, they redefined the definition of regularity. So the normal variation, the shortest to the longest is 7 to 9 days. It's no longer 2 to 20 days, 7 to 9 days. And it has shown variance depending on age. So if the patient belongs to the 18 to 25 group, the normal variance should be around less than 9 days. 26 to 41 years old should be less than 7 days. And 40 to 45 years old, it goes back to less than 9 days. Okay? So the normal variation of the cycle length is plus minus 4 days. So that is the variation. Now for the duration of the flow, they remove shorten. Wala nang shortened flow. So it's either prolonged or normal. So a normal duration is 4 to 8 days. And a prolonged flow is more than a week, no? More than 8 days. So there are only two categories in duration. Now here, in the volume, it is no longer quantifiable, but it is based on the heavy, normal, or light. So it depends now on the assessment of the patient, no longer the clinician. Hindi na po yung clinician ang measure if it is more than 80 or less than 5 ml. So nice. The group of nice definition, the excessive menstrual blood loss which interferes with a woman's physical, social, emotional, and or material quality of life has been enforced. Okay? So it just shows that HMB is a symptom and not a diagnosis. So it is patient determined. And the last that they included in the system 1 is intermenstrual bleeding. Now, the definition here is that it is a spontaneous bleeding occurring between menstrual periods. Okay, it can be either cyclic or random. Okay, so in between menstrual periods. Okay, so this is how it appears. Okay, so this is how it appears. So you notice that there is the frequency, duration, regularity, flow volume, and you just check if it is present or not. And then you can already identify whether the menstrual cycle is abnormal or normal based on the categories here. Okay, so this is the a chart that is being used. You can download this and you can use this in the clinic, especially if you are encountering AUB patients. Okay, this really helps. And now if we go to our system 2, what are the revisions that were done in the system 2? So this is the this is the 2009 system 2, and these are the revisions. So what the first revision is in AUBA. okay, in adenomyosis. So if you notice before, they used MRI. Now, it is not. It is based on ultrasound diagnosis. This is where Musa comes in. Okay? So next is AUBL. Now, the AUBL, now they included, again, it is an ultrasound diagnosis. And in the AUBL, they now consider type 3 as a submucous Lyomyoma. Remember that type 3 is just on above or just touching the endometrium. It is majority of it is located in the intramural and touching the endometrium. Now they consider that as a submucous myoma. And there's differing distinction between the types, no? Type 0 and 1, 6 and 7, types 2 and 3, 4 and 5. We will discuss that later. Now, in next that they did a revision is coagulation, coagulopathy. Now, they are now included. They excluded drugs that impair blood coagulation. And these drugs are now transferred to AUBI, that's iatrogenic. Okay? So, including the use of pharmacological agents used in anticoagulation and those thought to interfere with ovulation. I remember it has been, have you experienced being, they usually refer patients, especially during dialysis, hemodialysis, they use coagulants during dialysis. And most of these patients are referred to me for management of AUB. No? And obviously, they belong to AUBI. No? So we would have discussions with the nephrologist when to stop the anticoagulant, etc. Just to control that AUB. Okay, so another revision is this one. Okay, so I mentioned that as the iatrogenic, and then the AUO. So AUBO, that's ovulation, it is now based on revision system 1. So you go back now to revision 1 on how you're going to define, how are you going to translate the presentation of the menstrual history or the bleeding history of this patient. And it has to exclude drugs that interfere ovulation. So it now ovulatory disorders associated with drugs known to suspect to interfere with ovulation, like drugs like anti-epileptic drugs. So those are the ones that interfere with ovulation. And the last is N. Now you notice that N, not otherwise classified. That was what they termed. They are now calling it as has been changed from not yet classified. Ayaw nila ng not otherwise classified, not yet. So it's about to be classified pa. So expect for a third revision of this FIGO pump coin. So there is a brief discussion, there is a brief discussion on the potential new cause of AUB. No, it's because we're getting a lot of niche, ismosil, no, following lower uterine segment cesarean section, and it's true. It can also present with AUB. There are some patients who would just complain of intermenstrual bleeding, and you will see that the prominent presence of the niche, no, CS car niche, and the ismosil is there. So in other words, the palm coin system, even if they did some revisions for 2018, it's just trying to understand the palm. No, understanding the palm is the structural disorders. Now, in the structural disorders, you only have to think of two structures there. One is the lesion coming from the endometrium, and second is it coming from the myometrium. And so the substandardization and so nowadays they are already into standardization of nomenclature. If we talk about AITA, you have to have the same language as that of AITA. If you're going to talk about Myometrium, you should be talking about Musa. No? So this is another way of understanding how come they are now using this kind of terminologies. And that is for one, standardization for us to understand each other. Two, for research. And three, it will also matter a lot in the management. Okay? So we are now going to walk through the endometrium and the myometrium based on AITA. I know that this is an ultrasound-based classification, but I hope for those who are not ultrasound oriented or has no, you will be able to understand because I'm going to always refer to the ultrasound report so that you will be able to understand what we are trying to tell you as ultrasound specialists. Okay? So we now start with AUBL, that's Lyomyoma. Now in Lyomyoma, so this is the subclassification system that was done by FIGO. So the PAM, the polyp, adenomyosis, so the Lyomyoma, so you notice here, the submucous is always 0, 1, 2, and 3. So that means that 0, 1, 2, and 3 is related to the endometrium. We all know that myoma is a myometrial lesion. No? It does not arise from the endometrium. So this myometrial lesion, when they included 3, because it recognizes that even if it has touched or that did not even put a lot of pressure on the endometrium, it can cause AUB. Okay, so that's why 0, 1, 2, and 3 are related to the endometrium na side. So that's why we have that submucous. And the rest is other. And this one is different naman. It is related to the distance to the serosa. No? So how far is it or how distorted is the uterine wall based on the serosa. So here, always remember that 1 is less than 50% intramural. So if you say that it is less than 50% intramural, it means that your myoma has pressed on the endometrium. And it is not much of an intramural. So dapat baligtad talaga siya. Okay? So in 2, it is more than 50% intramural. So how are you going to compute this? You just get the dimension, the mean diameter, and if it is less than 50%, this intramural component from the mean diameter of the mass, then you can now label it as 1 or 2. And no need for measuring the 3, but because it is 100% intramural, and that inferior portion that abuts with the endometrium is enough to say that this is a submucous myoma. Now, for the 4, 5, 6, 7, and 8, so it is already in relation to the serosa. So it's the reverse naman. It's the reverse. Okay? So meron pa silang hybrid. No? Ang hybrid, yung meron silang hyphenated, 2 to 5. So ibig sabihin, it follows all. No? Sa lahat, si 2, si 3, si 4, at saka si 5. So kinuha na niya lahat. So the entire myometrium is occupied by this type of myoma. Okay. So ito na yung difference na ano. So type 0 and 1, intracavitary lesion to the endometrium by a narrow stalk. So ito yun, the narrow stalk. That's type 0. So if there is a stalk, then that is the less than 10% or mean of 3 diameters of the Lyomyoma. So that's how you measure it. I haven't, we're just lucky if we can see the stalk, no, by ultrasound. But if you see it, if you see one, you try to measure it so that you will know if this is type 0 or just type 1. No? It will help especially for those who are performing hysteroscopy. That 0 and 1 will really matter a lot. No? It is easy to resect a type 0 than resect a type 1. No? Sometimes a type 1 might be type 2. No? But a 0, you're sure that this is a submucous myoma. Okay? So in type 2 and 3, intramural portion of the lesion. So it mentions the intramural portion of the lesion in relation to the endometrium. So at type 2, it is at least 50% or more. And at type 3, it is 100% intramural. So, but it touches the endometrium. So the reason they said that the type 3 formally distinguishes the type 2 with hysteroscopy using the lowest intrauterine pressure to allow visualization. So we do this in SISH, enhanced imaging, and we can, aside from, of course, the hysteroscopy, it can aid in the differentiating the 2 and the 3. Okay? So here is some images that I will represent. So this one, definitely this is a type 0. By using the rendering, we notice that there is a stalk here. So it confirms that indeed this is a type 0 myoma. So here, because of we know that it is a submucous myoma, and I cannot make a type on this case. For one thing, it already covers the entire cavity, so I don't know. So maybe if I am the ultrasound specialist in this case, I would request for an enhanced imaging so that I can easily make the topography of this myoma, submucous myoma, and tell and distinguish whether it is a 0, 1, or 2. Okay? So now we go to the 4, 5. No? So these are the intramural leiomyomas that we always see, and most of the time we measure it, and in FIGO they only mention 4 myomas that you can measure. But some clinicians would want you to count all the myoma. So not that I'm complaining, but you know how difficult it is to measure all these intramural myomas. Okay, so, but getting the type, you distinguish the 4 and the 5 here. Again, in relation to the serosa, it's no longer in relation to the endometrium. So in relation to the serosa, your type 5 at least has 50% intramural. So 5, 6, and 7 are all subserosal. They have already reached the serosal area. So 5, 6, and 7. So of course in 5, there is less than 50% intramural. Less than 50% intramural. So it's the reverse sa submucous. And in type 7, there is already that stalk, no? The same as your type 0. So measurement of the stalk is the same as the type 0. You measure it, it should be less than 10% or the mean of 3 diameters of the myoma. Okay, for the other, so these are for the other classification. So the hybrid, so it compasses the transmural, and it is a relationship between the serosa and the endometrium. So ito yung hybrid. So when you look at the hybrid, you always note the endometrial relationship first and the serosal relationship second. So mauuna muna yung sa endometrium because if the relationship to the endometrial relationship, that is already a submucous component of this myoma. So if you look at the endometrium, now for the type A, it's different for the type A. So type 8, the myomas, they do not relate whatever to the myometrium at all. So these are the cervical lesions or those myomas that are found in the round or broad ligaments with no direct attachment to the uterus, or what we call as the parasitic lesions. These are the parasitic lesions. So these are the type 8 Lyomyoma. Okay. So if you are curious, how come, and patients will always ask you, Doc, bakit po yung mama ko may myoma din, ako din meron? Okay? They mentioned before na this is more of an initiator progenitor cells, but the studies have shown that there is this genetic hypothesis in the molecular mechanisms of myoma. And if you notice that stem cells, these are the progenitors, and if you notice it is the onset is in the myoblast, the embryonic myoblast of the female reproductive system. So if the stem cells, if the mutation, the gene mutation is in MED12, it will account for the multiple myoma that we see in our patients. Ito po yung we sometimes say na ito po yung myoma pong pinigyan po ng nilagyan ng matres, not the other way around. Mas marami po yung myoma kaysa sa makita mong normal na uterus. So these are the multiple small and medium fibroids. So ang genetic hypothesis here is ito ang gene mutation is at the MED12 gene mutation. So it causes excessive connective tissue growth, activation of the early genes. No? So that's why there is this multiple leiomyoma. And now, in the other pathway, so this is the epigenetic disorder in leiomyoma using the NHMGA2 gene. So usually it is provoked by the enhanced expression of this gene, and it will cause hypomethylation and epigenetic deregulation. And it will be enhanced by hypoxia, muscle tension, and chromosome instability. So these are the epigenetic disorders. These are the type of stem cells that would cause a solitary leiomyoma. So these are the ones that will cause the large size fibroids that we see. These are the women, most of them are infertile, and we have difficulty in trying to manage them, especially if they have this huge myoma, and worse if it is at the submucosal area. So our friends in the repromed subspecialty, I think they know what to do with these patients. Okay, so just a quick discussion on peripheral vascularity of the myoma. The reason for the peripheral vascularity of these patients is first, if you look at this diagram, you notice that the vascularity, it just encloses the fibroid, no? So it feeds on the existing vas vessels, and then it will feed inside the lesion, so that it may grow, and it will have an effect from the hormones. You notice that the vascularity is at the periphery here. Okay, so exactly here. That's how it looks. So that is the how you distinguish a fibroid from an adenomyosis. Okay, so anong type po yan? Of course, type yan sa type 4. No? This is type 4. Medyo hindi pa siya sa malayo po siya sa endometrium. Okay, now adenomyosis. AU. So there are two types of adenomyosis, diffuse and local. Integrated siya sa non-invasive diagnostic approach, no? And identification and characterization of adenomyosis matters a lot, especially when you look at the clinical symptoms and clinical examination and combined with imaging. That's why we really have to understand what Musa is. And it has an epidemiologic scenario. You see women having this huge uterus and keep on complaining on pain and at the same time having that AUD. And this is the type of vascularity that you see them. It is intralesional. It enters into the uterus, no? And most of them have problems with fertility. And mind you, some of them are asymptomatic, but majority of them are with endometriosis. So just a quick review on the histology. So if you look at this histology, if you look at this endometrium, so this is the functional layer, and this is the basal layer, and this is the myometrium. You notice that there is no clear demarcation between the functional layer and the myometrium. That is a normal. This is a normal appearance. Now, if you notice this area, there are some glands that has entered beyond the basement membrane. This is the reason why there is adenomyosis. No? So we know that the definition of adenomyosis, it has to be composed of stroma and glands within the myometrium. There should be endometrial stroma and glands. And these are endometrial stroma and glands entering into the myometrium. Okay, so this is one. And of all the regeneration that will occur in a lining, the uterus, the endometrial lining, is one that is very fast in regenerating because of our menstrual cycle. So remember, you have a functional layer that is being shed off every month. So it regenerates and regenerates. So it encounters trauma, it encounters healing, and go back and forth, back and forth. And that will cause that the presence and the entry of these endometrial glands into the myometrium. Okay? So when you look at this one, so you notice that most of the endometrial glands are inside the myometrium. And of course, the myometrium is a muscle layer. It will react to that estrogen, it will react to that tissue injury, and it will react to that hypoxia. That's why making that angiogenesis. So it is the one that is going to form or cause AUB and subfertility in adenomyosis. And it is the one that is the culprit. No? So the theory that it is because of menstrual reflux, that is true, but actually it is the formation of the angiogenesis or the angiogenesis theory that is the culprit in the causation in the AUB and subfertility of adenomyosis. So here is the I downloaded this from YouTube so that we can understand what is angiogenesis. It is the same as that of tumors. No? Just imagine that the tumor is that endometrial implant or that endometrial implant, and it will form new vessels. So that is the of angiogenesis. So in the capillary or the endothelial layer, so this is the wall. and it is composed of basement membrane. Because of the presence of that endometrial implant within the myometrium, it will cause formation of new vessels coming from that existing vessel in the capillary area. And there is a disparity between the high oxygen and the low oxygen. So that disparity of the high oxygen and the low oxygen, it will break down that extracellular matrix of that endothelial cell. And from there, it will start releasing VGF, or those that will break down the barrier of the endothelial cell. And there will be a tendency for this vascular endothelial growth factor, or VEGF, to break down, and it will now attach to the receptors. And once they have broken down, it will now form, and it will connect now to this endometrial implant and supplying oxygen now to this hypoxic area. So that is what they are saying, that it is now the reaction of the myometrium to that angiogenesis. That's why we have that Musa. So it is a diagnostic criteria, and it shows the graphic depictions on what is happening. So there are 9 criteria for the Musa. Now in the 9 criteria, first, the usual that you read from our ultrasound report, asymmetrical myometrial thickening. Usually it's in the posterior wall. The posterior wall is thicker than the anterior wall. And presence of myometrial cysts or hyperechoic islands, or that fan-shaped shadowing. These words, these terminologies might be familiar to all of you because we usually describe this in the ultrasound report. Or echogenic subendometrial lines and buds. Translational vascularity. And if a 3D was done to demonstrate the junctional zone, then the junctional zone is irregular and it might be interrupted. Okay, so if you notice that all the criteria are all reactions of the myometrium to those implants, as what I demonstrated in the other slide. So that's the angiogenesis that is occurring every time your patient menstruates. Okay, so identification and evaluation of the junction, Endomyometrial junction, may be best accomplished by 3D ultrasound. At least there should be a presence of 2 or more of these criteria, and presence of 2 or more is highly associated with the diagnosis of adenomyosis. So we don't need to have all 9 criteria to be present. Okay? So they say, what is pathognomonic findings for adenomyosis? An enlarged uterus and the junction. Now, if the junction, some authors would say it's more than 12 millimeters, it is highly predictive of adenomyosis. But if it is less than 8 millimeters, it does exclude. It excludes the disease. But that is just one of the criteria for the Musa. No? So this is not the only criteria for us to make a diagnosis of adenomyosis. But its presence would certainly increase the risk that this uterus is adenomyotic. Okay? So these are the different features of the myoma, of the uterus. So here you have the thickening of the myometrium. So it is irregular, and you have this fan-shaped shadowing. Okay, you have here, there's this myometrial cyst. It looks the same as the echo as the endometrium, and this is the myometrial cyst. By 3D, this is the endometrium, and the junction now is gone, is interrupted because of the presence of this huge mass. And this mass is the one that is here. Okay, so that is the adenomyosis. And if you get the color flow, and this is the glass body, you can see the vasculature and the distribution of the blood vessels. It is intralesional, and it is not peripheral. Okay, it is diffuse in distribution, the vascularity. Okay, so in short, all the ultrasound images reflect the myometrial responses to an abnormal vascularization. So my takeoff for this is, if in the early stages of adenomyosis, and you see that the clinical signs and symptoms of the patient is really related to an adenomyosis, like severe dysmenorrhea, progressive dysmenorrhea, yet you see the uterus is still nice, no? It's still normal looking, does not look like this one. I would suggest that you treat her like having an adenomyosis, so that it will not progress to this one. Because once it has progressed to this kind of appearance, ultrasound appearance, then there's no way of treating this one, because this is already a fibrous myometrium, no? Because of the constant inflammation that it has encountered every time this patient. We have to look beyond endometrial thickness. So you always remember that in the reproductive age group, the thickness is not that important, unlike in the menopause. In menopause, the thickness is more important because there's a cutoff for them. Now, a menopause should be less than 4 millimeters. It should not be beyond 4 millimeters, or else we'll think of something else. Unlike in a reproductive age patient presenting with AUB, the best here is you have to look beyond the endometrial thickness. And that is the reason why we have to understand AYITA, and what is the International Endometrial Tumor Analysis is all about. And we are just talking about the endometrium. We have to get the best image of the image quality of the endometrium. Kasi you take note, ayite yung pinag-usapan natin, tapos di natin nagagawa ng maayos ang endometrium. So how can you now assess the endometrium if your endometrial stripe or your endometrium is not of the best image quality? So how do we do the best image quality? They say it is recommended that the probe should be 90 degrees to the sagittal plane of the uterus, or the sagittal plane of the endometrium. Okay, so that should be the 90 degrees. So if you look at this one, this is the probe, this is the signature of the probe, and it should be 90 degrees of the endometrium. So you are able to see all the fine structures of the endometrium. So this is the best way to start with AYITA. You will not understand AYITA if your images are not correct. You have to get the best image quality of the endometrium. So now, there are two ways to examine the uterine cavity. It is unenhanced or enhanced. So in unenhanced is what we usually do routinely. No? So we examine the uterine cavity, but the first step is quantitative, and that is the endometrial thickness. So endometrial thickness, you can see if there is the presence of lesions, if there is fluid. Now, if there is presence of fluid, you should measure it separately. If none, then you have to measure it from the 1.1 to the other. And take note that it is in millimeters. Kaya for those clinicians, nagre-reklamo, bakit millimeter yan, hindi centimeter? Kasi po, pag millimeter, it is more accurate. you can measure it to the last millimeter, unlike kung centimeter po. And you have to round it to 1 decimal point. 1 decimal point. Now, for the sonologist naman, for the ultrasound specialist, please do not convert the millimeter to centimeter, because that is not, you are not doing the standardized way of measuring the endometrium. It has to be in millimeters. Okay? So if the endometrium is not clearly seen, just place there non-measurable. You do not have to imagine that there is an endometrium, because we can only see all these structures. These are the structures that is typically seen in an endometrium. The midline, echo, and the anterior and posterior part of the endometrium. And of course, the junction. Okay? So, now we go to the qualitative. So, this is the tricky part. No? So, it has to be detailed. So, it's a detailed assessment of the endometrium. So, just imagine just a simple, there's a little part of the uterus, it matters a lot. It matters a lot. So, the first that we have to look at is this uniform or is this non-uniform? So how do you say that this is uniform? If it is uniform, it is like para siyang 50 grays, 50 grays na book, or I call it the 3 grays, no? The 3 grays. Now, yeah, there's this spectrum of color with gray, because this is a grayscale, no? Kaya nakita nyo, grayscale yan siya, ang 2D ultrasound. So there's a spectrum of the tone of the grayness, no? The grayness of the image. And the reference point there is always the myometrium. So if the grayness, it is hyperechoic than the myometrium, so we call that as hyperechoic. If it is lesser in grayness to the myometrium, we call it the hypoechogenic. And if it is the same, like this one, the same as that of the myometrium, it is isoechogenic. Okay, so that is the uniform. So in non-uniform, it is heterogeneous. Why is it called non-uniform? Because all three gray tones are there. You have the hyper-echoic, you have the hypoechoic, and you also have this anechoic, which is the cystic. And that is not even included with the uniform endometrial echogenicity. So a presence even of the cystic structures will already tell you this is not uniform. Okay, this is not uniform because there is the cystic structure in the endometrial area. So it is a heterogeneous or a asymmetrical or a cystic endometrium. Okay, so that is one. So that is one qualitative assessment that we have to look at the endometrium. Now here we go. Here is the example. So now, what do you see? This is the sagittal plane of the endometrium, and this is the transverse plane. So do you see the midline? What is the ecotexture of this endometrium? Is it uniform or non-uniform? Okay, so I see some cystic areas here. There's a cystic area here. So automatic, this is non-uniform. Okay, so this is heterogeneous. So the echogenicity of this endometrium is heterogeneous. It is non-uniform because there is areas there that is hyper. There is an area here that is anechoic, and some areas that is hypoechoic, and even isoechoic parts. Okay. So the next thing that we have to look is the midline, endometrial midline. So what is this endometrial midline they're talking about? This endometrial midline actually is the interface between the anterior and the posterior endometrium. It is the interface between the anterior and the posterior functional layer of the endometrium. Because it has nothing in the cavity, it will abut each other. So that's the interface. Yan yung line na nagawa. Because they are kissing each other. Itong anterior and posterior. So if there are structures in between, this line is not linear. Okay? So the normal is here. It is a linear thing. Kasi malinis siya. Linear. And if there is something that will interfere with this interface, then it is nonlinear. And there and we can say it is irregular if you do not see the endometrial midline, no, but some fragments of it, no, fragments of it, and there is no connection from the line itself. And the last is the midline is not defined. You cannot see the midline. Okay, so these are the four the descriptions of the endometrial midline. So here is the endomyometrial junction. So the midline and the junction, it appears regular. So if it is regular, so you see the gray zone is very, very clear. So this one is the gray zone here. So that is regular. It is irregular or interrupted irregular. So it is not, it is a little bit serrated, no? But still you can identify the junction. And if the endometrial myometrial halo is interrupted, then you can always say that this is, you can say it is irregular or interrupted regular, or if it is not interrupted, it is regular. So it is the halo. Some would say it is the halo, some would say it is the dark gray. But I will show to you the images here. So we go back to that image. So what do you think is the midline here? Do you see the midline in this case? Yes, we see this. This is the midline here. All of a sudden, it is interrupted and another midline here. So this is an interrupted or an irregular endometrial midline. Do you see the junction? Okay, so I see the junction here in the posterior. I also see the junction here. Okay, for me, this is regular, but some of you might say this is irregular. No, this might be interrupted. So again, it is subjective. Again, it depends on how you see it. But at least you were able to identify what a junction is, where the junction is. Mine is midline is nonlinear. The endomyometrial junction is an interrupted regular junction. So that is another qualification or another criteria for the qualitative assessment of the endometrium is this bright edge. What is this bright edge? It is the interface of the lesion and the endometrium. Diba sabi natin kanina, the midline is the interface between the anterior and the posterior functional layer. Now, the bright edge is the interface between the lesion and the endometrium. Kasi nga, nandyan siya yung nag-break doon sa ating midline. Now, another curious thing that they included is sinike. No? So I try to understand how come they place it in a different category for this ayeta. And true enough, it presents different. It is different from the abnormal or the not so normal changes in the midline and even in the junction. So once you've seen this, and these are the strands of tissue crossing the endometrium, you expect no tissue to be crossing the endometrium. Diba? So the endometrium has its own, it is autonomous, has its own area, it has its own territory. And tissues crossing it always think that there might be adhesions there. And adhesions are fibrous tissues, sometimes from the myometrium. Okay? And then another that we have to qualify is a presence of intracavitary fluid. Now, it is not enough that we see an intracavitary fluid, but we have to define or describe what type of intracavitary fluid is inside. Is it anechoic? Is it ground glass? Or is it of mixed echoes? Okay? So, so these three are unique appearances of the endometrium. You might not find them most of the time, but once you find them, you already know what it is, especially if it is syncytial and bright edge. So it will only confirm that true enough that there is a lesion in that endometrium. It is not saying that this might be a polyp or a fibroid. It is just saying that there is an intracavitary lesion within the endometrium causing this bright edge. So here are the same images. I did not change the images, so we're just using it for purposes of practice. Now, just one trick that I would like to share to those who are practicing ultrasound. You notice in this part here, this is the gray. This is the gray scale. And one trick, if you really want to look into the details of the endometrium or any structure for that matter, you just change the grayscale. And this one, put on the tint. No? So this is the cool blue. No? You know the knobs, there's this knob there. You can use it, so it's a sub knob there. You just switch on and then change the hue, change the tone of the uterus, and you can see distinctly what you want to look at. Okay, so here you see, here in the gray, when I put on the cool blue, okay, you don't need to have a 3D ultrasound, but you need to have a very, very good ultrasound, okay? Really good ultrasound equipment for you to appreciate all this what I'm talking about. So you notice that the junction, I can clearly see now the junction. So the junction here at the posterior area is intact, here at the fundal, and here it is still intact, here and here. Okay, now I can see the midline. Okay, very well. So obviously we are right that this midline is not non-linear. Okay, because there is an interruption here, but the junction is regular. Okay, because I just switch on something that is always there. Change the color so that you can get to see what is better. No? Sometimes your eyes will get used to the gray. You change the color, you can see a lot of things after. So next is this intracavitary fluid. What is this? Describe this intracavitary fluid. Okay? So I can hear, ayaw ko lang, virtual o baka kasama ko lang may multo sa tabi ko, nagsabi na anechoic. So anechoic. Okay, so this is anechoic, no echoes. Okay? Okay, so I'll stop this. Even the slightest fluid in the cavity, you will be able to appreciate the endometrium. So you notice the posterior endometrium here, anterior endometrium, the junctional layer here. Look at the junctional layer around it. And you know that this is a thin endometrium. So that is what I was saying. If you just look at the thinness or the thickness of the endometrium, that does not tell you anything. You look beyond it, and then you will be able to appreciate what this is. For me, this is an atrophic endometrium, I would say. If I don't know the age of the patient, I would immediately say this is an atrophic endometrium. But if you're going to give me a 30-year-old with this kind of endometrium, what are you going to think first? I'm going to ask first the patient, are you taking pills, OCPs? Because this is the pill effect of the OCPs or any contraception, hormonal contraception. It will always cause thinness of the endometrium. So this is just normal for woman in the reproductive age group taking OCPs. So with a little bit of fluid inside, it will help a lot. So now we go to the color Doppler. So it did not end there. So we quantified, measured the endometrium by standardized manner, get the qualitative description of the endometrium. Now they're going to give us color and power Doppler assessment of the endometrium. But before we embark into the color and power, we have to know by heart the settings. It is useless to get to do color power Doppler assessment if you do not know the settings, because these are the settings that they have placed in the AITA. And we are not there to change it or modify it. So ito po, you have to use a frequency ultrasound of 5 megahertz. So it means that you use most of the time transvaginal. PRF should be at zero point 0.3 to zero point 0.9. The wall filter should be at 30 to 50. And you have to reduce color power gain until all color artifacts disappear. So those are the requirements. And we have to, and for those ultrasound specialists, please know it by heart. It's useless embarking into color flow, color power Doppler without any knowledge of these settings. So you will really get different interpretations of the color power Doppler, especially for the vascularity. Okay? So the vascular pattern is the first that you will check. Vascular pattern, what did they do with the vascular pattern? It's just where it came from, the origin. If it comes from a focal origin, next is it branching or not? So the first single dominant vessel without branching. So that is one vascular pattern. Then the second vascular pattern, you have one focal, but they are branching. So there are multi-vessels, but they are coming from one common stem. Okay, so that's one with a focal origin. So this is how it looks like. Now another is for those vascular patterns with several focal origins. So we call that as multifocal. So it has different. So most of these multifocal origin arise from the junction, from the endomyometrial junction. So that is the uh, exact criteria for this multifocal origin. Okay? And the next is there is no focal origin, no multifocal origin. You don't know where they came from. They are scattered vessels. And they are dispersed color signals within the endometrium without visible origin at the junction. Okay? So without, well, so one, get the origin. May origin ba siya? Then next, is it single or multifocal? The branching can be either in the single, multiple, or multifocal origin. And then if they have no origin, then those are scattered vessels. So that's how you describe the vascular pattern. So this is the multifocal origin at the endomyometrial junction. And this is the scattered vessels. Okay, so look at the settings, it's 0.3. So you have to follow the set. Next is enhance. Now we go now to the enhance. Why is it important to enhance? Actually, the enhanced imaging is for you to identify if there is a lesion or not. And if it is a lesion, is it myoma, submucous myoma, or polyp? Okay, but you also have to look further into the appearance of the endometrium. So the first thing that you have to do by doing saline infusion sonography is first you have to distend that uterus. Now, you can label it as optimal if the fluid clearly distends the cavity, suboptimal if it is barely distended, and filled if no fluid is seen in the cavity. So this is the first step. Then next is get the endometrial outline. No? So the folds, is it smooth? Is it polypoid? Or is it irregular? So anong bang itsura ng ano mo? So if it is smooth like this one, and if it is irregular or multiple, thickened, undulating. So these are the different descriptions. And then next is if you perform an enhanced imaging on a CNK, you will notice that the thin and thick strands of tissue crossing the endometrium will be similar to that of the myometrium. Okay? And it is attached to the uterine walls and it is not covered by the endometrium. So it has already traversed that basement membrane that in between the functional, the basalis layer and the myometrium. Okay, so typical of adhesions or fibrous tissue. And lesion, smooth or regular. If that there is a lesion, is it smooth or regular? And the lesion will have to be measured for it to be determined, is it localized or extended? And if it is localized, is it pedunculated or sessile? So ito yung mga ratio. No? So you can only perform this in an enhanced imaging and an optimal enhanced imaging procedure. You cannot perform this if you do not have fluid in the cavity. No? Sayang lang yung effort. And this is the myoma. No? So here we can make the type. No? Is it type 1, type 0, type 1? Here, look at this one. So it is not in the but this is already the type 3. No? So you notice this one. So a portion of the myoma has already touched the endometrium. So that's 0, 1, 2, and 3. Okay, so this is the 3D rendering of a type 0 myoma. Okay, so if you see this, so this is one example. So if you see this, you will notice that it has a single, no branching vessel pattern. Okay? So the transversion, and then you will see that there is still no branching. No, it is consistent. It's what they call as the single pedicle artery. I hope I'm right. So it enters into that lesion. So if you are the ultrasound specialist. For me, I would be happy with that. I already know the diagnosis. But if you want to pursue further this case, then you can put the imaging and put this enhanced imaging. So in the first image, an enhanced image, you only identified one polyp. But here in the enhanced, you were able to identify that there are more than one polyps, and you were able to assess that there is this niche. Okay, there's this CS star niche or isthmusile. So you were able to see more with an enhanced imaging. Okay, and also some portions of thickening of the endometrium. Okay, there's a irregularity of the endometrium. Okay, so you will be able to look further into the uterine cavity doing an office procedure like a CISH. Now, there's this ABE, no, the endometrium. So they say that this is the disorder of the endometrium. So how come you have this ABE and it is predictable and cyclic? So you can apply this with intermenstrual bleeding. So typically, it is given to ovulatory cycles without other identified causes. So this is secondary to local vasoconstrictions, accelerated production of plasminogen activator, and the prolonged bleeding reflects the deficiencies in molecular mechanisms of endometrial repair. See, diba? I told you, I mentioned earlier, it is every month that endometrium regenerates and it has to repair by itself. And anything that will affect the repair will cause bleeding, no? Prolonged bleeding or intermenstrual bleeding. And sometimes infections. No? Infections are, are the cause, or taking the OCPs wrong can also affect the endometrium. Okay? So now we go down to the diagnostic algorithms. So what is the diagnostic algorithm? This is the one that is recommended by Monroe. So in chronic AUB, so 3 months, so are we going to apply this with Miss Sarsi? So Miss Sarsi has been complaining of excessive duration for 2 months. She had 2 or 3 months. So we can label her as a chronic AUB. So yes, so initial investigation, physical examination, so check the uterus, do the pelvic exam. But in pandemic, we are not doing that. No, not much are being. We choose to do some mitigating measures in our practice. We are going to discuss that later on how to approach this problem during the pandemic. So so there's this structured history. You try to get the ovulatory function, is it for future fertility, and of course the medical history of the patient, and then screening for inherited coagulopathy. And ancillary investigation for to rule out any endocrine problem and also coagulopathies. So if there is none, then in the uterine evaluation, you already ask, is there a risk for hyperplasia or neoplasia in this case? Or is there a risk for just a structural abnormality? So if it is just for a structural abnormality, then an ultrasound is necessary. No? And it will help us assess the endometrium. And of course, and if there are if there is an abnormal endometrial cavity, then there is a choice between a hysteroscopy or a CISH. Okay? So here we can see if there is a target lesion, is there really a lesion? And if it is difficult, then you can consider getting an MRI. Okay? So, however, for if the patient is at risk for an hyperplasia or neoplasia, then you can go straight with getting an endometrial biopsy. Okay? But an endometrial biopsy is as good as it gets, no? If you are able to get more specimen, then your yield will be higher. And it will also tell you, and if the yield is higher, then it will tell you immediately, it will answer your question, is this hyperplasia or neoplasia? And manage accordingly. But however, if it is not, if it is not atypical, no, then you have a presumptive diagnosis of PAMCOIN, AUBE. It might be an endometrial disorder or an ovulatory dysfunction. Okay, so this is how the diagnostic algorithm is recommended by FIGO. So I am sure that before we are writing like this, AUB, P0, A0, like this. Now they are recommending a graph, a table. So this is the table. You can have this in the clinic. And this will tell you first, the first visit of the patient. So it will just guide you. So do you think this is a polyp? No. Is this an adenomyosis? No. So from the ultrasound? No. So is there an ovulatory disorder? Yes. You presume yes. So the rest. So the question mark is you have not done it yet. So if you have not done it yet, so put an X in coagulation and in endometrium. And in the next visit, having done all the tests to eliminate whether it is C or E, then you will be able to make already your diagnosis according to PAMCOIN. So is there a structural abnormality? a structural problem? So yes, there is the myoma. And is there an endometrial problem? Yes, it's an E. Okay? So this is how you approach it. Then from there, you have already made your diagnosis and the treatment accordingly. So take note that this L0, so it means it is a submucous myoma. So chances are the problem with the AUB of this patient is more of a structural affecting the endometrium. Okay, so then you go back to the history, fertility, desirous of fertility, etc. And that will now, you will now manage it accordingly. So it means that at least your management is according to the etiology and not to just controlling the AUB. Okay, so it ends with a treatment, it has to be individualized. It must be individualized. And the treatment goals in PAMCOIN is that using this classification will facilitate accurate diagnosis and inform treatment options to patients. And it will also increase the availability of medical options, no? Rather than and less of that surgical option. So medical options are preferred as the initial treatment of abnormal uterine bleeding, especially in the reproductive age group. So that is the stand of PAMCOIN. So when you do the treatment goals, you have the acute AUB. So you check on the stability. Do you need to replace the volume, stop the acute abnormal uterine bleeding? That's for acute AUB. So these are the medical options. It may be a COP, OCPs, your progestins, non-hormonal, tranexamic, yung antifibrinolytics, or a mechanical, a tamponade, no? Place a Foley catheter just to stop the bleeding for acute AUB, no? While waiting for the medical treatment to take its effect. While on the other hand, for the chronic AUB, so you have to apply the classification of PAMCOIN for you to know what is its etiology. And there is a specific treatment for each PAMCOIN. So for example, if it is a polyp, then obviously it has to be resected. And if it is adenomyosis, medical or hormonal treatment, and if it is really affecting the patient, she might need a hysterectomy. If it is a myoma, then you know that the bleeding is very common among myoma, patients with myoma. So using the Mirena agonist and the surgery, embolization, hysterectomy, and HIFU, no? And malignancy. No? So you have to do the staging. Check is she a good candidate for surgery? If not, hormonal treatment like high dose progestins or radiotherapy as palliative treatment. So for the non-structural, if it is coagulopathies, then just the antifibrinolytic, the tranexamic acid. Ovulatory dysfunction, check. Most of them are PCOS, might be obese, or check on the endocrine. Endometrial, so no specific treatment as mechanisms are not yet clearly understood, but they still have this category. And sometimes this might be confused with the other AUB. If it is iatrogenic, then check on the offending drugs. You can withdraw it. If it is not, it cannot be withdrawn, then you can use the other hormonal treatments or other treatments given in other categories. And if it is not otherwise classified, so entities like endometritis, AV-mal, or embolization might be necessary, like AV malformation, so embolization. So just a quick interventions commonly available during pandemics. This is a Cochrane review for 2020. So they try to do a systematic review on all Cochrane Cochrane Studies reviews concerning what is the effectiveness and safety of treatments commonly available during pandemics for heavy menstrual bleeding. So because one thing that they would like to emphasize is that SARS-CoV-2 has no impact on AUB of any type, including symptoms of heavy or irregular menstrual bleeding. But they want to emphasize that they are at risk for iron deficiency, anemia. And, and the goal here is you have to improve a woman's quality of life rather than treating targeted blood loss. Okay? So, the new normal is mas marami na po pumupunta sa primary care. No? Most of our women now consult the primary care. The secondary care has instituted mitigating measures to prevent the transmission of the COVID-19. So it created backlogs sa healthcare system. So we have to have these efficient pathways to manage women with AUB. So if they are managed effectively in primary care, better. For as long as it will enhance or it will improve the quality of life of these women. But if in the primary care they are ineffective, then they have to refer it to the secondary care. And in the secondary care, there is a need for efficient pathways to manage the women with AUB. So like triaging, appropriate triaging, we are now using teleconsultations to move women efficiently through the treatment ladder, no? So they don't need to see you. So there's no need for the unnecessary face-to-face. And accommodates social distancing and separating COVID positive from other groups. So that's one thing. No? So especially there's already this surge. So in the study, they said that if there is 1,000 women with HMB from the review, reported improvement, 766 of them said they improved with just by taking NSAIDs. And 401 using the OCPs. And antifibrinolytic is 363 and placebo is 109. So in 1,000 women with AMB, 329 perceived that their menstruation went back to normal with placebo. Okay? So they now recommend treatments that can continue during the pandemic. NSAIDs. No? So you can use mefenamic acid or naproxen. So because it will reduce prostaglandin levels. Antifibrinolytics, no? The tranexamic acid. It will inhibit clot dissolving enzymes. There's combined hormonal contraceptives, the combined oral contraceptive pill. It will thin out the endometrium. Your progesterone, no? Norethistedone, it will also thin out the endometrium. So there's just such a thing as short cycle. It is taken for 10 days of the menstrual cycle, or long cycle taken for the 3 to 4 weeks of the menstrual cycle. So these are the treatments that can continue during the pandemic. And what is the implication for practice? So from in terms of evidence, level of evidence, the moderate or certainty in evidence, if combining your antifibrinolytics and pills, OCPs, it will reduce dramatically heavy menstrual disorder, bleeding. And NSAIDs, if you compare it with placebo, NSAIDs, instead of placebo, give NSAIDs. So it has a low certainty in terms of evidence. Antifibrinolytics are more effective in reducing heavy menstrual bleeding in the short or long cycle of progestogen. So instead of giving that progesterone, maximize on the antifibrinolytics. But there is no conclusion on the quality of life, women's satisfaction with treatment, or serious adverse events taking these medications. So women with HMB, HMB yan dapat. During pandemic, it is recommended to prescribe tranexamic acid or antifibrinolytics, NSAIDs and the COCs. And when health services will be available, so you do the complete examination now for the pump coin and should be done like physical exam, blood test, or ultrasound. In the NICE recommendation, they immediately recommend hysteroscopy. They want hysteroscopy, and in some clinical pathways, they also recommend giving the levonorgestrel intrauterine system as the first line. If the patient will not avail with the system, then you can then you can use the algorithm that they recommended for the drugs that are beneficial or that will work during the pandemic. So, so it has to be, I have to mention the evidence-based interventions in the investigation of HMB, because this patient was immediately recommended the DNC. Now, according to the POGS, CPG, DNC is category 1 intervention. So it is an intervention that should not be routinely commissioned or performed. You only do the DNC if you need to know to get a biopsy. Okay, so we were taught. I don't know. We were taught before that the DNC is both diagnostic and therapeutic, and I think it disproves that DNC is not diagnostic because we can use the diagnostic algorithm being presented to us by the pump coin. And treatment is according to the etiology. And it's not the DNC that will treat the AUP. So the hysterectomy is another intervention, and it is labeled as category 2 based on evidence-based intervention. And it should be only routinely done or performed when there is specific criteria. And that is being met both by the clinician and also by the consent of the patient after appraising the risk and benefit of the procedure to her in relation to the etiology of the abnormal uterine bleeding.